and admit all.
Good afternoon, everyone. We'll be getting started in just a moment. We'll just there's a couple minutes to join us and we'll get started right at noon. Just a note for everybody joining us that today's webinar, your microphones are muted, but feel free to use the chat function for any questions you may have through today's session. Please also note that today's webinar recording and presentation will be distributed via email to all attendees after the webinar has concluded within 1 to 2 business days. And we'll just give another minute or so for the others to join us. All right. Well, welcome everybody to today's On My Mind webinar hosted by the My Mind Collaborative Quality Initiative. We're really thrilled to have you guys join us today. My name is Jason Robertson, and I'll be your host for today's session. I'd first like to announce that today's webinar is approved for 1 CME CEU credit. You have 23 hours from the conclusion of today's webinar to text the unique code that you see on the screen to the telephone number that you see as well. The details for CME CU credit are in the meeting invite for those of you that received one, and it will be also displayed on screen at the conclusion of today's webinar. Before we get started, I'd also like to share 2 brief disclaimers. The views and opinions expressed in this webinar are those of the speaker and/or speakers and do not necessarily reflect the views of Blue Cross Blue Shield of Michigan or Henry Ford Health. The content presented in this webinar is related to suicide and supports the mitigation of suicide risk. If you find yourself struggling emotionally or have suicidal thoughts, or you know someone who is, help is available. Call or text 988, the Suicide and Crisis Lifeline, 24/7 to connect with free, confidential support. Now it's my pleasure to introduce today's presenter, Dr. Anthony Reffi. Dr. Reffi is a licensed clinical psychologist and co-director of the Sleep and Traumatic Stress Institute at Henry Ford Health. He leads a research program focused on the intersection of sleep and trauma and acute trauma populations with the goal of informing early interventions for PTSD and other post-traumatic sequelae. He serves as associate editor for the European Journal of Psychotraumatology and Sleep Advances and is on the editorial advisory board for the APA Journal of Psychology Trauma. Dr. Reffi is currently funded by the American Academy of Sleep Medicine and the National Institute of Mental Health. Today, he will review the state of the literature on the links between sleep and suicide, with a specific focus on insomnia and nightmares, the theories and putative mechanisms behind the sleep-suicide relationship, and emerging evidence showing the effect of behavioral sleep medicine on reducing and preventing suicide risk. We'll plan for about 45 minutes of presentation, followed by 15 minutes for questions and discussion. Before we begin, just a quick couple reminders. All participant microphones are muted for today's webinar. Please use the chat to submit your questions at any time during the presentation, and we'll address them at the end of the session today, being monitored by Sarah on our MyMind team. So please ask your questions along the way, and we'll make sure those get answered at the end. With that, let's get started, Dr. Reffi. The floor is yours, sir.
Alrighty. Fantastic. Thank you very much, Jason, for that introduction. And let me just get myself set up here with my laser pointer. I'm going to need that. Alrighty. Well, yes, thank you very much to Jason and the MyMind team for inviting me, and thank you to everyone for attending. Very excited to speak with you today on the relationship between sleep and suicide. So I have a couple of goals for us today. So I will begin with a discussion on the associations between sleep, in particular insomnia and nightmares, and suicidal thoughts and behaviors. So in my area of research, I focus on insomnia and nightmares. So that's a big reason why I'm going to be focusing on those two sleep disorders today. And in addition, the bulk of the literature on sleep and suicide has found very robust links between insomnia, nightmares, and suicide in particular. I'll then transition into a discussion of why we think these relationships exist, and then I'll get into some practical information on what can we do about this. So I'll go over evidence on the effect of sleep-focused interventions on reducing and preventing things like suicidal ideation, and then some tips on how you might want to screen for these different sleep disturbances. Okay, so starting with the links between insomnia, nightmares, and suicide, I want to start by just beginning with a definition of insomnia. So when we talk about insomnia, clinically speaking, we are talking about people who are experiencing difficulty with either falling asleep, staying asleep, or waking up too early. And when we say difficulty, we are operationalizing that difficulty as 30 minutes or longer. So taking 30 minutes or longer to fall asleep, spending more than 30 minutes awake in the middle of the night, or waking up 30 minutes or more before one's alarm. This sleep difficulty has to occur at least 3 days a week, present for at least 3 months, and accompanied by daytime symptoms. So things like difficulty concentrating, distress, functional impairment. And very importantly, insomnia occurs despite the adequate opportunity for sleep. So what that means is that the person has to have trouble sleeping even though they have the chance to get plenty of sleep. So if somebody comes into your office and they're complaining of sleep disturbances, and then you find out that they work two jobs and they're a single parent, it's probably not the case that they have insomnia, but rather that their circumstances are what is what's driving their sleep problem. So now that we have a sense of what insomnia is, we can start to look at the literature that shows an association between insomnia and different components of insomnia and suicide. So in this study, they recruited a large nationally representative sample, and they looked at these different parameters of insomnia that I just spoke about. So trouble falling asleep, trouble waking up too early, and then this last piece I didn't talk about, but hypersomnia is when people have a lot of daytime sleepiness and are suffering from unrefreshing sleep despite having a lot of sleep. So these people with hypersomnia might sleep 9, 10 hours, but still feel like they could use more sleep and are struggling with a lot of excessive daytime sleepiness. So they looked at these three types of sleep disturbances in this very large population, and then they looked at rates of suicide attempts or no suicide attempts. So we can see differences between people with these disturbances. So what they found was that people who had trouble falling asleep were at much greater risk of making a suicide attempt in the future. Similarly, people who had early morning awakenings were at increased risk for making a suicide attempt, and same thing with hypersomnia. And this was a prospective design, so these patients were followed over the course of 3 years. So when they were modeling the relationship between these different types of sleep disturbances and suicide attempt, this was looking at the risk for a future attempt 3 years later. And also very importantly, these relationships held even after accounting for very important confounding variables such as comorbid psychopathology, medication use, and prior suicide attempts. Now, there was another study that looked at individuals with depression, and they separated them into three different groups. So patients with depression who had no suicidal ideation, patients who had suicidal ideation only, and then patients who actually made a suicide attempt. And then they wanted to see how these groups differed, if at all, on their insomnia symptom severity. And consistent with the previous study, they found that those patients with depression who had attempted suicide had the most severe insomnia severity, as opposed to patients who only had SI or patients who had no SI or made any attempts at all. And this again was robust to important covariates such as severity of depressed mood, anxiety, and PTSD. And then the last study I'll focus on in regards to insomnia and suicide was another very large population-based study, a prospective design. So they followed, or they looked rather, at patients over the course of 14 years. And then on the y-axis here, we have cumulative risk for suicide. And they wanted to look at patients who had a diagnosis of insomnia disorder in their electronic medical record versus those who were not diagnosed with insomnia as per their medical record. What was the cumulative risk of them having made a suicide attempt over time? And again, very consistent with the rest of the literature, we find a considerably higher risk for suicide attempt over time for patients who had a diagnosis of insomnia disorder in their chart versus those who did not. Okay, so now we have a sense of the literature on insomnia and suicide. So now I want to pivot and talk about the literature on nightmares and suicide. And again, just like we did with insomnia, I think it's important to first start off with a definition of what nightmares even are. So the definition we use when we are discussing nightmares are disturbing, well-remembered dreams that cause awakenings. Now, why do we have this very specific definition? So we say that nightmares are well-remembered dreams because that helps us to distinguish nightmares from something like night terrors, which on the face of it can look very similar to nightmares. So in both nightmares and night terrors, the person is waking up abruptly from sleep, very frightened, panicky. But in night terrors, the person does not have any recall of having had a dream. And that's because dreams and nightmares do not precipitate night terrors. The person wakes up for seemingly no reason in this state of fear and panic. Now, contrast that with nightmares. The person is waking up. They might look the same as the person waking up from night terrors, very afraid and panicky, but they have a very clearly well-remembered, vivid, disturbing dream that caused them to wake up. And the reason that we like to stipulate that nightmares cause awakenings is because this helps us distinguish nightmares from what we might just call ordinary bad dreams that don't cause an awakening. Now, I invite everybody to just take a second to think about a nightmare they've had, perhaps recently, a nightmare that you've had, and think about, again, a nightmare that actually caused you to wake up. And think about that feeling where the nightmare really kind of rips you out of that dream. You're suddenly awake in the middle of the night. You're feeling very frightened. You're having these sort of panicky symptoms, and you have those brief moments where you're not quite sure what's real and what isn't. And this is a qualitatively different experience from a dream that doesn't wake you up and that you only begin to vaguely remember at some point later in your day when something reminds you that, oh yeah, I did have a dream last night and that was kind of weird and unsettling, right? Those are two very different experiences. So an awakening you could think of as really a proxy for severity. And there's good evidence to suggest that there is a good reason to distinguish bad dreams from nightmares. So this is a really interesting study that recruited patients who were hospitalized for some suicidal crisis, which they defined as patients coming in for suicidal ideation or attempts. And they looked at the progression from bad dreams to nightmares leading up to the suicidal crisis. So what they found was about 4 months prior to the suicidal crisis, 67% of patients reported having bad dreams. And then as we get closer to the crisis, 3 months prior, just over half reported having nightmares. And then just 6 weeks before the suicidal crisis, almost a quarter reported having suicidal scenarios during their dreams. So what this tells us is that nightmares and sort of the progression from bad dreams to nightmares might forecast suicide risk and really serve as a warning sign for providers. And just quickly, some other studies that support this relationship. One study found that patients with monthly to weekly nightmares were more likely to be hospitalized for a recent suicide attempt as compared to those with yearly to no nightmares. And similarly, having nightmares several times a month was associated with a twofold risk, increased risk for future suicide attempt, again, above and beyond prior suicidal behavior, sleep duration, sleep quality, and insomnia. Now, as Jason mentioned at the start, my area is really at the intersection of sleep and trauma. And while I won't talk too extensively about trauma today, trauma and suicide, of course, are significantly overlapping. So it bears mentioning, albeit briefly, the relationship between nightmares, trauma, and suicide. So nightmares, we know, are very common within the acute aftermath of trauma. And in one study that we recently published out of our group at Henry Ford, we recruited patients within about a week after a traumatic event, and we followed them over time. So 1 month post-trauma, we were able to look at patients who had neither nightmares nor insomnia, compared to patients who had insomnia only, and then finally compared to patients who had both nightmares and insomnia. And we looked at the relationship between those sleep disorders 1 month post-trauma and rates of suicidal ideation 2 months post-trauma. So again, we have a nice prospective design here. And what we found is, again, very reminiscent of the previous studies I've discussed, which was that the rates of SI were much, much higher in those who went on to develop nightmares, both nightmares and insomnia after their trauma, as opposed to those who had insomnia only or neither of these types of sleep disorders. So nearly half of all patients with comorbid nightmares and insomnia were reporting some level of SI 2 months post-trauma. Now, when we talk about nightmares after trauma, many people may have started to wonder about trauma-related nightmares. So when we experience a traumatic event and we begin to have nightmares, we can have nightmares that fall anywhere on this continuum of trauma related content. So they can be quite dissimilar to the trauma, or they could become increasingly similar to the trauma, where we start to see a lot of elements of the traumatic event showing up in the dream content, but it's still not exactly like the traumatic event actually unfolded. And then we can have nightmares that are exactly or almost exactly like the traumatic event. We call these trauma replicative nightmares. And what the literature has shown is that trauma-related nightmares confer far worse outcomes, really across the board. And for the purposes of today's talk, I'm citing just one study here that looked at trauma-related nightmares and their relationship with suicide reattempts. So these are patients who had already made a previous suicide attempt, and this was a sample of veterans. And what they found was that even after controlling for anxiety, depression, and what we call idiopathic nightmares, which is to say nightmares without a known origin, trauma-related nightmares were uniquely associated with suicide reattempts. So above and beyond all of these other variables that we know are in and of themselves risk factors for suicide, trauma-related nightmares emerged as this independent predictor. Okay, so starting to tie together this first section on the links between insomnia, nightmares, and suicide, there is really this robust literature on the relationship between these sleep disorders or these sleep disturbances and increased risk for suicidal thoughts and behaviors. And these are using, in some cases, very large samples and lots of studies that are longitudinal and have prospective designs. And they control for a lot of important covariates. So what that tells us is that this relationship is not merely symptoms of comorbid disorders. So it's not just because people have something like PTSD or depression and they're having sleep disturbance as a symptom of that. No, these relationships exist above and beyond those comorbidities. Same thing with medications and same thing with prior attempts. These relationships are robust to these covariates. So what this tells us, put simply, is that insomnia and nightmares seem to have this really unique role in the impact on suicidal thoughts and behaviors. Okay, so this brings us to why. So we understand this association exists, but I haven't spoken about why we think this happens. So one model I want to talk about is what's referred to as the mind after midnight hypothesis. And essentially what this model postulates is that, maybe it's not any particular sleep disorder per se, that explains the link with suicide. But maybe instead it's the resulting nocturnal wakefulness that follows. So what does this mean exactly? So if we look at just population data, we know that most suicides occur around noon. So here we have time, and we see that the peak in risk for suicide is highest around noon. And this makes sense because most people are awake during the day, and that is a prerequisite for any kind of behavior. But what happens after you adjust for population sleep and wake timing? What you find is that the risk for suicide is substantially increased at night. So now we have this black line that you see is peaking around 2 a.m. So there's over a four-fold greater risk for suicide at 2 a.m. relative to the 24-hour average. So what does this mean exactly? So while more suicides happen during the day in total, in terms of sheer raw numbers, it is those who are awake at night who face a disproportionately greater risk of suicide. And the thinking behind this is that we're not supposed to be awake at night. And this is where the name Mind After Midnight comes into play. Our mind is not operating at its best in the middle of the night when our usual processes that might otherwise inhibit suicidal thoughts and behaviors are offline because we are supposed to be asleep. So another way to think about it is to think of this question, which is it a bad thing to be awake when reason sleeps? And what this suggests is that when we are awake in the middle of the night, we are really not at our sharpest, right? We're not really firing on all cylinders. We don't really have our best ideas or make our best choices in the middle of the night. So to break this down even further, if we are awake in the middle of the night and experiencing sleep loss, there's a lot of good evidence showing that we are just more emotionally labile. We are more prone to ruminative thinking and worry, which increases things like anxiety, depressed mood. On top of that, we have a much harder time regulating these strong emotions, controlling this kind of negative, perseverative thinking, and inhibiting our behaviors and impulses. And finally, if we're awake in the middle of the night, we have much less access to social support, right? We might have a spouse that we can wake up if we need it, but if not, it's going to be very hard to get a hold of somebody if we are experiencing some kind of a crisis. So when you put all of these variables together, you have this synergistic effect that increases risky behavior. So what is the evidence supporting this mind after midnight hypothesis? So one study brought people in and they randomly assigned them to two conditions. One condition got normal, healthy sleep, so they were allowed to sleep a full 8 hours. And then another group was randomly assigned to this no sleep condition. So these people were sleep deprived, so they were kept awake all night. And then these people in both conditions were put into a scanner to look at their brain while they viewed negative emotional stimuli. And the researchers were interested to see what happens in the amygdala, which is the fear center of the brain, when people view negative emotional stimuli under conditions of normal sleep or conditions of no sleep. And what they found was that in the normal sleep condition, the amygdala responded in a very typical way. And in the no sleep condition, what they found was that the amygdala showed this very exaggerated response. So to unpack this a bit further, it's important to understand what's happening at the level of the brain when we are in some kind of a stressful situation or are dealing with some strong emotion. So under conditions of normal sleep, the prefrontal cortex, pictured here in green, has this really nice relationship with the amygdala. So again, the amygdala is a fear center of the brain. So when we experience something stressful, if we are in a dangerous situation, if we're under some kind of threat, if we're experiencing trauma, the amygdala lights up, right? The amygdala is going to become activated because this is going to trigger the fight or flight response. So this is a very normal adaptive response. And then what happens over time is the prefrontal cortex comes online when we are no longer in that dangerous situation to tell us that, okay, we are now safe. We don't need this fight or flight response any longer. So the medial prefrontal cortex communicates with the amygdala that we don't need this response anymore, and it really puts the brakes on the amygdala. So it's able to downregulate this fear response. Now, when we don't get healthy sleep, this connection between the medial prefrontal cortex, which is really sort of the executive of the brain, is decreased. So the medial prefrontal cortex is not really able to communicate with the amygdala in the same way. So we're not seeing that nice top-down inhibition of the amygdala coming from the medial prefrontal cortex. So this leads to this continued overactive response from the amygdala, even though there's no real reason to have this fear response any longer. Okay, so images of the brain lighting up are all fine and good, but how does this translate to real people in the real world? So this study looked at the relationship between sleep and suicidal ideation. And what they found was that people who got shorter than usual sleep went on to experience more intense suicidal ideation and more frequent occurrence of suicidal ideation. And very importantly, this relationship was mediated, or in other words, explained by heightened affective reactivity to negative interpersonal events. So in other words, the reason that getting shorter than usual sleep was predictive of future suicidal ideation was precisely because people were more reactive to negative events in their life. So maybe they were getting more irritable, they were quicker to snap at people, they were feeling more frustrated, more agitated interacting with their spouses, and they were having much stronger negative emotional responses. So this was sort of this explanatory mechanism by which shorter than usual sleep was related to suicidal ideation. So this maps on very, very neatly to those imaging studies that I just talked about. Now, if we go back to nightmares and try to connect nightmares with the mind after midnight and really contextualize the experience of nightmares within this model of the mind after midnight, we can think about how when we don't have nightmares, for most of us who aren't experiencing chronic nightmares or nightmare disorder, sleep is really this period of reprieve, and most of us really look forward to sleep, right? This is a period in the day where we're able to rest, recover, and reset. And this gives us a break from our daily life and our stressors. When somebody is experiencing chronic nightmares, they no longer have this reprieve from sleep. So there's almost really no escape from their distress. They're struggling during the day with things like fear and anxiety, and now when they go to sleep, they're getting more of the same. So instead of sleep being this signal for reprieve, it instead is this connotation of hopelessness, defeat, and entrapment, right? Because there's this sense that they really can't get away from the thing that is haunting them, especially if they are trauma-related nightmares, because in essence, a person is reliving their traumatic event each night that they go to sleep. So there's really this pronounced fear and this strong sense of hopelessness, which we know are risk factors for suicide in and of themselves. And now again, if we tie this together with the other factors in this mind after midnight, you can see how nightmares can really compound this risk. So in one of the studies I referenced that we did in our lab here at Henry Ford, we collected information on our patients' nightmares. So we actually had them record their nightmares and then we were able to transcribe them. So I only have two here just to give you some reference for what these nightmares might look like for people. So for this patient, they said that a few nights ago and a few times in the past month, since I went to the ER, I've had dreams that my ex-boyfriend is attacking me, similarly to what happened when I had to come when I had to come into the ER. It always happens late at night, and I'm choked or attacked and fearing for my life in every dream. So this is a trauma nightmare, of course. And when you analyze the content of the dream, you could see that there is this strong threat present in the dream. There is intense fear. It's happening late at night. And here's another one. My crash is the only thing I've been dreaming about lately. I'm getting flashes of everything that happens in the dream, how I threw my arm over my fiance to brace her for the impact. I'm waking up in cold sweats because I'm constantly having flashes of the impact. I can't sleep, or at least get comfortable to go to sleep, because every time I close my eyes, I'm seeing the crash. I'm seeing my family almost being taken from me. This is very disturbing. So again, you can see how the experience of reliving this nightmare is really reinforcing this trauma memory. It's reinforcing this sense of not being able to escape and not being able to move on from it. And this brings us now to another model that helps us understand why insomnia and nightmares are linked with suicide. And this is called the sleep to forget, sleep to remember hypothesis. All right, so this model is based on literature showing that when we sleep, the brain is actually helping us to consolidate memory while simultaneously stripping the emotional charge from that memory. So here's just an arbitrary image depicting a memory, and wrapped around it are the emotional components of that memory. So as an example, this might be a memory of somebody getting into an argument with their spouse, right? So we have the memory of that event, and then we have the emotional memory associated with that event. So we have maybe frustration, maybe sort of chest tightness, maybe some sadness even. Now, when this person goes to sleep, the emotional charge of this memory is going to dissipate. And then when they go to sleep the following night, the emotional charge is going to dissipate more. And then if we fast forward to some future date after X amount of sleeps, we get to a point where all that's left is the memory itself, but it's completely stripped of its emotional charge. And again, I invite you to think about a memory that you have of something that was stressful or had some otherwise emotional components to it. Maybe it's an argument you had with a spouse or friends or your kids. If you think back to one of those arguments that happened many, many moons ago, you'll be able to remember that event, and maybe you'll remember the emotions you felt, but you're not going to have that same visceral emotional reaction anymore to that memory, as opposed to something that maybe happened yesterday, right? Maybe you got into traffic yesterday and you were feeling very frustrated, or some kind of road rage event. You might still have the sort of the tinge of that emotional memory still lingering because it happened so recently. Now, going back to nightmares, when a person is experiencing nightmares, which again is waking them up, nightmares are consequently preventing this emotional processing function that we would otherwise get from sleep. So here we have the same memory and its emotional components, and when the person goes to sleep, they are awoken by a nightmare. So it is preventing this emotional component of the memory from dissipating. Not only is it preventing that, but it's reinforcing the emotion and could even be strengthening its emotional charge, because the person isn't simply waking up in this affectively neutral state. They're waking up in a very fearful, panicky state. So they are actually having this fear memory reinforced and these reactions reinforced. So to tie up this theories and mechanisms portion of the talk, we know that more suicides happen during the day, again, in terms of raw total, but it is those who are awake at night who face a much higher risk of suicide. And we think this may be due, at least in part, to important biological systems, starting at the level of the brain, being offline during nocturnal wakefulness when we're supposed to be asleep. And nightmares seem to really exploit these vulnerabilities of nocturnal wakefulness. So another way of thinking about this is insomnia and nighttime wakefulness is really sort of like the kindling, right? And insomnia and nocturnal wakefulness can really prime the mind for rumination, distress, and greater impulsivity. And nightmares really are the match that ignite this risk, because nightmares help to, again, reinforce this sense of defeat onto this already fatigued, disinhibited mind that is prone or vulnerable to suicidal thinking. And this brings us now to our treatments for sleep and how these treatments affect suicide risk. Okay, so in keeping with the structure of the talk thus far, I'll first talk about our treatments for insomnia, and then I'll move on to our treatments for nightmares. So in the interest of time, I'll just briefly talk about cognitive behavioral therapy for insomnia, or CBTI, which is the frontline behavioral treatment for insomnia. It is 6 sessions typically, and it consists of these different components, which again, if we have time at the end, I can go into more detail if people have questions. So in another study from our group here at Henry Ford, we looked at the effect of CBTI on suicidal ideation. And this actually was digital CBTI. So this was a fully automated digital delivery of CBTI using an app. And down here on the x-axis, we have immediately post-treatment, and then we have 1 year post-treatment, and then we'll have 2 different groups. So people who went through this digital CBTI and people who were in a sleep education control. So for a lot of our clinical trials that use sleep treatments, we tend to use sleep education and sleep hygiene as a control, because we know that sleep hygiene and sleep education is really not enough to help somebody with clinically significant insomnia. So it works as a good control group. And then on the y-axis here, we have percentage rates of suicidal ideation. So when we look immediately post-treatment, we see that those who received the cognitive behavioral therapy for insomnia group had about 30% suicidal ideation, or not about, exactly 30%, as compared to those who received the control condition, over half reported suicidal ideation. And when we look at 1 year post-treatment, we see that these effects were durable over time. So in other words, these weren't just acute effects that washed out over time, but rather we still see about 30% in the CBTI condition having SI, compared to, again, close to half in the control condition having SI. Now, what if we look at people who at baseline had no SI? So if we do that, we can look at CBTI's effect on preventing new onset SI in people who never had SI to begin with prior to treatment. So now on the y-axis, we have new cases of suicidal ideation. On the x-axis, we still have immediately post-treatment and 1 year post. And now our groups are going to be a little bit different. So these are patients in the dark gray bar who would have remitted from their insomnia diagnosis, which is to say they no longer met criteria for insomnia disorder after treatment, or patients who did not remit. So what we found was that those who remitted, there were very, very low rates of new onset SI, just 1.5%, versus 6.5% in those who did not remit. And again, 1 year post-treatment, we see slightly different numbers, but a similar pattern where those who remitted, there was only 3.8% new onset suicidal ideation, as compared to 7.4% of non-remitters who went on to develop new onset suicidal ideation. So what this tells us is that CBTI not only helps to reduce suicidal ideation, but it can even help prevent new onset suicidal ideation. The mechanism here seems to be remission of insomnia. So it's not simply because these people went through an active therapy and other people went through a control condition, but rather it is by very virtue of the fact that these people had their insomnia remit, or they were able to improve their sleep, that we saw these effects on suicidal ideation, these preventive effects. And we're now starting to see similar findings across across different settings, across different populations, and using different treatments. So another study looked at brief CBTI, which is only 4 sessions instead of the 6, and they found that even just 4 sessions successfully reduced suicidal ideation, and this was in the primary care setting. Now, another study, this was very interesting, they did chart review in the VA. So they were looking at veterans with sleep disorders, and they looked at those who had sleep disorders and wanted to see if going to sleep medicine visits was at all related to a future suicide attempt. What they found was that utilization of sleep medicine appointments decreased the likelihood of a veteran having a suicide attempt 6 months later. So this was a slightly different kind of study design. This wasn't an RCT, a randomized controlled trial like the other studies, but it nonetheless really fits with this same pattern, suggesting that if you treat sleep, you have these downstream protective effects on suicide risk. And this was a study that importantly looked at suicide attempts as their outcome, as opposed to suicidal ideation like our study and these studies here. And this is just to show you that there's a lot more work being done in this area now. So this is a protocol for a systematic review and meta-analysis. So in other words, this is a group of researchers who are planning to do a whole review of the literature on CBTI as a suicide prevention strategy. So the reason I'm putting this here is because this signals to us that there's enough literature out there now to start doing these systematic reviews and meta-analyses to see, if you analyze all these studies together, what is the literature telling us about the impact of this treatment on suicide? So this is something that is still forthcoming, but I wanted to just mention it briefly. And now let's get into CBT for nightmares. So again, in the interest of time, I'll just talk a little bit about the loose scaffolding of what this treatment entails. So it's also 6 sessions, just like CBTI, and it integrates the core components of CBTI that we know are the active ingredients to help with insomnia. And on top of that, it has this targeted nightmare work, of course, because it's a nightmare treatment. So again, I could talk more about this if we have time and questions at the end. And there is emerging evidence now for the impact of treating nightmares on things like suicidal ideation. So there are 2 studies that found that nightmare-focused treatment did help to decrease suicidal ideation, and a recent study, hot off the presses, it was non-randomized, but it's still the first controlled study that was able to look at nightmare treatment and its impact on SI on patients with major depressive episodes. So they found a large effect on nightmare treatment in SI. So this is that same study and looking at the results slightly differently. So here we have on the x-axis patients who had what they called a suicide ideation response. So in other words, patients who showed at least a 50% or greater reduction in SI after either the active nightmare condition or again their sleep education control. So we have in yellow the active nightmare group, in blue is going to be the control. So if patients had a positive a positive suicidal ideation response, that means they had a greater than 50% reduction in SI. And then on the y-axis, we have the number of responders here. Okay, so what we see is that of those who had a suicidal ideation response, we had far greater responders in the active nightmare group. So in other words, those who went through the nightmare condition, we had more people, or they had more people who had a 50% reduction or greater in SI after that active nightmare condition as opposed to the sleep education control. So to summarize this section, we have a lot of evidence now that CBTI can effectively reduce and even prevent suicidal ideation, and this effect really seems to be explained by insomnia remission, which is to say it's the targeting of the insomnia that is the mechanism explaining the effect on suicide risk. And the evidence for nightmare treatment on its effect on suicide is nascent, but it is growing, and we need more work in this area. Especially, we need to extend the literature on these treatments and their impact on not just ideation, but suicide attempts. Okay, and this brings me to my last section of the talk today, which is on screening. So I've made a lot of noise now about, okay, insomnia and nightmares are important for suicide risk, but how do we actually detect these? Okay, so if we are interested in assessing for insomnia, the best tool that I would recommend is called the Insomnia Severity Index, or the ISI. It's a nice quick 7-item scale that assesses for those core nighttime symptoms that I talked about: difficulty falling asleep, difficulty staying asleep, and problems waking up too early. And then it has the daytime symptoms afterward. And then they have a nice breakdown of how you can categorize people by these different categories. And if even that is too much, because I can appreciate that everybody's burdened with screening for everything under the sun, there is evidence that a brief 3-item version of the ISI can work to detect people who are at risk for clinically significant insomnia. So these items are 3 of the 4 daytime items, getting at dissatisfaction with sleep, worry and distress about sleep, and functional impairment. And the cutoff using these items is a score of 6 or greater. So in other words, if you were going to administer anything, these 3 items seem to do the trick. And if people score at least a total of 6 or greater, that is a good indication that they probably have a significant sleep problem that needs to be addressed. Now, with regard to nightmares, we have the Nightmare Disorder Index. This is a quick 5-item scale. The first one's asking, do they even have nightmares? If not, great, you can move on. If they do, and they have the nice definition here of what are nightmares, then they answer these following 4 items that ask about how often the nightmares wake them up, how much distress and functional impairment they experience, and then just how long they've been bothered by nightmares. So this last item, item 5, is really just a time specifier. It's not necessary for this screener. So if you were going to use just the 4 items, that's totally fine. And the boxes that are grayed out is just a helpful visual to let you know that patient scoring in those gray boxes are at risk for a serious nightmare problem. So of course they have to have any nightmares as opposed to no nightmares, and then they have to be waking up, having distress and impairment at the level of somewhat or sometimes, which you can think of as moderately or greater. And then lastly, because I know many people will be using the PHQ-9 already, if you're not able to add anything else to your assessment battery, and I totally understand that, you have a item built into the PHQ-9 already that can at least give you a sense of who might be struggling with their sleep. So the PHQ-9 item 3 asks about trouble falling or staying asleep, or sleeping too much. So that actually gets back to one of my earlier slides of hypersomnia, which we saw was also associated with suicide risk. So you can get a sense of if somebody might need some more targeted sleep work based on their response to this item alone. So to summarize the entire talk, sleep and insomnia and nightmares in particular have been shown to be associated with future suicidal thoughts and behaviors above and beyond known risk factors, whether it's benzodiazepines, sedatives, tranquilizers, comorbid depression, comorbid PTSD, previous suicide attempts. These relationships still hold. And this is across all different populations: healthy adults, nationally representative samples, veterans, trauma samples, you name it. So we can safely say that sleep really seems to be a warning sign for us to know who might be at risk for suicide. Why does this happen? Well, we think it's because of the impact that these sleep disturbances have on us overnight, and in particular, their promotion of nocturnal wakefulness. So their increase in emotional lability, and you could think of this as sort of equation: sleep loss plus emotional lability minus our ability to regulate emotions, our ability to regulate behavior and impulses, minus social support equals greater risk for self-harm and also other directed harm. So we know that nighttime is associated with things like homicide as well, not just self-directed harm. Nightmares, again, reinforce all of this and really compound the impact of nocturnal wakefulness on suicide risk. Again, there's a lot of evidence now that targeting sleep is one method for curbing this risk. This is seen across different populations as well. And given my area on trauma, specifically acute trauma, one thing that we're doing now is we're looking to see if we can actually deliver these sleep interventions early after trauma, can we see these downstream predictive effects on things like suicide and on things like PTSD? And this is a study that we are piloting right now across our health system. And finally, if you wanted to screen for any of the sleep disorders, the ISI, you can use either the full 7-item version or the abridged 3-item version. You could use a nightmare disorder index, which is only 5 items, or 4 items if you want to cut out that time specifier question at the end. Or if nothing else, you just want to stick with the PHQ-9 because that's all you're able to do. Item 3 might be sufficient to help you at least get your foot in the door with a patient to learn more about their sleep. And finally, I just want to acknowledge our funders, so the National Institute of Mental Health and the American Academy of Sleep Medicine. I also want to thank my mentor, Dr. Chris Drake at our Sleep Center at Henry Ford, all of our team at the Sleep Research Center, and our great collaborators across our health system within the Division of Trauma and Acute Care Surgery and the Department of Emergency Medicine. We have a lot of great supporters of our work, and I really appreciate everybody's help. And of course, I want to thank our patients who very generously volunteer their time to participate in our research. And I want to thank everybody else for attending today and for their attention, and I'm happy to answer any questions. And really quickly, before I turn it back over to Jason, if people are interested, I can talk more about this. There are great online trainings for CBT for insomnia and nightmares. If you're wanting to learn more about how you can deliver these treatments, or if you have trainees and you want to upskill them in these treatments, these are fantastic resources that I have no involvement in, but they are really just premier resources. And I'll skip over that in the interest of time.
Awesome. Thank you, Dr. Reffi. What just an incredible display of the work that you do. And thank you for sharing your knowledge with us today. We really appreciate it. It's a very informative presentation. We'll now move into our Q&A for just about 10 minutes. If you haven't done so already, please type your questions into the chat function, and Sarah on our team will share them with Dr. Reffi, and I'll pass things over to Sarah to do some Q&A stuff now.
Thank you, Jason, and thank you, Dr. Reffi. That was a great talk. You're getting lots of praise and good things in the chat here. Lots of people saying great talk, excellent presentation, exceptional information. So there's those things coming in, of course, and probably will continue to come in. I know James said when you were talking about the slides related to the amygdala, that he said impact of substances on timing would seem to me factors as well, but didn't necessarily pose a question there. So James, if you have a specific question, just let us know on that one, okay? Outside of that, okay. Where is the CBTN training? Jane asked. If you're aware of that, Dr. Reffi.
Yeah, so I don't know if I'm still sharing, but I went back to the slide here on the CBTI and CBTN web trainings. Are you all seeing this now?
Yep.
Okay. Yeah, so if you look down here, you'll see cbtnightmares.org is for the CBTN training, and then cbtiweb.org. And I think I did see a comment come in about how these trainings unfortunately are no longer free. So the developers really tried their best to keep it free for as long as possible. I think CBTI Web was free for almost 5 years, but they are at the point now where to sort of maintain the website and things, they do charge for creating an account and going through the training. But I really do believe that it's well worth the cost, and then you'll have access to not just those trainings, but a whole rich library of session handouts, different clinical measures, including the ones I talked about and other ones. And they also give you access to the treatment manuals, both the provider version and the patient-facing version, which has additional handouts and things. And then they also offer consultation groups for these treatments. So when you go through the training, they'll reach out to you and let you know, hey, in 3 months we have this consultation group starting if you want to join it. And you could participate in that to pursue certification for either CBTI and or CBTN.
Awesome. Thank you. Um, Annie Gerard asked, so is the study all based on those who have had trauma? The study that you were talking about.
Oh, yes. Yes. So very briefly, here's a sort of visually frightening flow chart of the study we're doing. So we are recruiting patients immediately after trauma within 72 hours. We follow up with them 2 weeks later to screen them for the development of sleep disturbance, because not everybody will have trouble sleeping, and even those who do might have just a acute stress response that will begin to dissipate after a couple of weeks. So we want to check in with them to see if they're still having trouble sleeping. And if so, then they get randomized to begin treatment. So they get put into either the active treatment condition or the control condition. So we triage them after that randomization. So if they have insomnia only, they get triaged to CBTI. If they have insomnia and nightmares, they get triaged to CBTN. And same thing with the sleep education. So we have just a sleep education group or sleep plus nightmare education. So both conditions are meeting with a provider for 6 weekly sessions, and then we follow up with them at 1 week immediately post-treatment, and again 1 month and 3 months post-treatment. So we are actively recruiting right now, and hopefully we'll have some good pilot data to submit to the NIH for a large, fully powered randomized control trial to do this with more people.
Very cool. Yvonne, I seen you hand your hand up, but I'm not sure that I can unmute you. Good, you put it in the chat. Okay. I have one more question, and I'll get to yours, Yvonne. Dr. Espiritu said, excellent talk, Dr. Reffi. Can you please comment on BCBT for suicide prevention and addressing global insomnia as a core component? Is the app Sleepio something that you would suggest?
Yes. Yeah. So the app is Sleepio, and I'm sorry. So were you asking about brief behavioral therapy for insomnia? Was that the other part of that question, I think?
Yep, that was the first part.
Okay, yes. Yeah, so I think there is evidence on that as well. So there was that one study I cited on brief CBTI, which was 4 sessions, and that I think functionally is you could think of the same thing as BBTI. So there is evidence that, even just 4 sessions instead of the 6 are helpful for addressing insomnia. And I can't recall if there was a third part of that question, addressing global insomnia as a core component. Yes, yeah. So the literature really does seem to suggest that that is really the crux that we want to target is the insomnia. Of course, if a person has nightmares, that's a slightly different equation. But if we're just talking about insomnia, it really seems to be the insomnia disorder that we want to target and try to treat to have this protective effect.
Thank you. And Yvonne Edwards asked, what explains time, and in parentheses, and sleep not seeming to decrease the emotional distress related to traumatic memories when they don't have nightmares, is the first part of the question. Then she also asks, sleep doesn't seem to decouple emotion from memory in these cases. Does the decoupling require dreams about the emotional memory within this theory? That's a
Yes.
two-part there.
Yeah, that's a really, really great question. Yes, so the dreaming does seem to be a very important ingredient in the emotional processing of memories, and more specifically REM sleep, so rapid eye movement sleep. So it seems like when people are not recovering from trauma, it is the disruption to REM. So they tend to have more fragmented REM, and they tend to spend more time in lighter sleep. So this can happen even without nightmares. So we do see a lot of REM instability and fragmentation in insomnia disorder. So it is possible to have that same kind of impact on the emotional processing that happens overnight during sleep, with or without nightmares. Yes. I'm
All
also now
right.
realizing
Oh,
that,
go ahead.
sorry, I know we're at time, but I'm realizing that the questions before, looks like it was about brief cognitive behavioral therapy. I think the work of Dr. Craig Bryan. And yes, I apologize, I misunderstood that. I am slightly familiar with that work, admittedly not as much as I am with the sleep field, so I can't really speak too much about that literature, but I am aware of it. And I see there's a comment here that they have looked at BCBT at reducing SIV, a reduction of insomnia. So I'm glad to see that there's some synergy between the literature there.
Awesome. Well, Dr. Reffi, thank you so much for everything today. We really appreciate it. Just before we wrap up, everybody, just a quick reminder about CME and CEU credit today. To receive credit for today's session, please text the code on the screen to the phone number provided. You have 23 hours from now to claim your credit. And on behalf of the MyMind team, thank you again to Dr. Reffi for sharing your expertise. And thank you to everyone who joined us today. Please note that today's recording and presentation will be distributed via email to all attendees within 1 to 2 business days. Your participation certificate will also be emailed to you within the next few business days as well. We look forward to seeing you at our next On My Mind webinar, which takes place on May 19th, 2026, with Dr. Amy Laurie, who will be presenting on addressing perinatal healthcare and healthcare systems. Thank you to everyone, and we'll see you soon.
Thanks, everybody. Take care.